then it spreads to the various parts of the body. There we say cancer is a systemic disease. Once cancer is a disease, systemic disease, there is no point in doing a localized disease. It is a combined modality of treatment. As I mentioned in my earlier sentences, the combined modality of treatment has brought in revolution and evolution in the management of cancer. What did we achieve over the decades by using the combined modality of treatment? One, we know that quality of life is more important. Everybody coming together, outcome results of cancer are important. And the most important thing is, it is not only the cure, the quality of life we give it to the patient, how they are useful to the society. Cancer rehabilitation is one of the important things. Today, you all know that we have seen the advanced technology in diagnostic armamentarium. Gone are the days of only chest X-ray was the only thing available to us 3 decades ago. Then we moved into ultrasound technology. We moved into CT scan. We moved into MRI. We moved into PET CT and various interventional things. Today, we can trace wherever the thing, what we call as using a PET CT, we can stage the disease and make it. In cancer treatment, the most important thing, the question asked by everybody is, doctor, what is my stage? Don't get feared. The phobia of cancer is more dangerous than the disease itself. You must know what is the stage of the disease. As we mentioned it, if you detect early, cancer is curable. Even if it spread to the stage 2 and 3, nobody should get. Today, as I told you, multi-modalities of treatment are there. Surgery is one of the modalities of treatment, followed by radiation, followed by chemotherapy, immunotherapy, hormone therapy, whatnot. These are the all we practiced for more than 3 to 4 decades. We understood the biology of the disease cancer. Then we realized that there are new concepts which came into picture. What is called as neoadjuvant treatment in cancer. What do you mean by neoadjuvant? We made a diagnosis of cancer, and then we know that we have to give a systemic treatment. We all understood the biology of the disease. When a cancer cell starts growing in the body, as I told you, it's a misguided cell. By the time it reaches 1 gram of tissues in the body, it has grown already 10 to the power of 9 times. This resulted in a concept, cancer is not a localized disease, it's a systemic disease. We have to give systemic treatment. And then concept came neoadjuvant treatment. In the past, we started off with the adjuvant chemotherapy, then hormone therapy. Today, we have moved into target therapies and immunotherapy. That is where the revolution has taken place. Why do we do that? Downstage the disease, make it operable, and patient can be brought from stage 2, stage 3 to stage 1 and 2, where the cure and control of the cancer is possible. What are the common cancer? As I told you, cancer doesn't differentiate age. Cancer doesn't differentiate sex. When that is so, there are common cancers in men, common cancer is in women. The cancer behaves differently in different parts across the globe. Cancer in Indian men and women is different from cancer in the Western world. That is why everything is more important to our relevance. How do we make an early diagnosis of cancer? Early diagnosis of cancer. Okay, the most important thing, cancer in women, we will take it. Cancer in women, the most important thing is the breast cancer, the cervical cancer, endometrial cancer, ovarian cancer, and all other cancers, colorectal mucosal cancers and other things. Some of these cancers are having what we call as cancer arises de novo, but cancer also arising from the known causes, what we call as chemical carcinogenesis. The most important chemical carcinogenesis we are seeing today is tobacco in various forms. As I told you, the lung cancer, which never we used to see in the past, now it has become more common. Even in the non-smokers, we are seeing adenocarcinoma of the lung in a women. Earlier we used to say that, head and neck cancer is more common in India, followed by esophageal cancer, gastric cancer. Now prostate cancer is emerging as an important disease. This is how we understood the biology of the disease. Cancer doesn't differentiate age and sex, we will tell. The cancer occurring is also very, very important. Today we see that in Indian subcontinent, more than 7 lakh new cancer cases are detected, including all parts of the body. As I told you, some of the cancers are preventable, some of the cancers are not. And some of the have got the viral etiology. We all know about it. Today, not only the COVID-19, in the past we have seen HBsAg, hepatitis B, and the liver cancers. Then we have seen HPV infection for cervical cancer. The vaccines have been developed, and also the HPV infection in the oral cavity. But then we know the nasopharyngeal cancer, Epstein-Barr virus. So virus is also one of the important causes. Because we understood the virus as one of the causes, various types of vaccines have been done and trying to achieve a control of the disease process. When we know that we know some causes of cancer and how to detect it, as I told you, we have to stage the disease. Once we stage the disease, then we know that treatment has to be given. And as I highlighted, that it is a combined modality of treatment is the order of the day for cancer. Now we will look into the common cancers seen in Indian subcontinent. As I told you, especially in women, breast cancer is number one, followed by cervical cancer. Especially here we classify into population which is living in the metropolitan cities, population living in the rural areas. In rural areas, still we see cervical cancer as number one cancer. In the metropolitan cities, we see breast cancer heading the list, followed by endometrial cancer, ovarian cancer, cervical cancer. Now we will take up breast cancer. Why do we harping on breast cancer? Not that all Indian women will replicating their lifestyles for the Western women, not so. There are various changes which is taking place in breast cancer. Breast cancer, as I told you, in India, when compared to the Western world, we developed 10 years earlier than the Western counterparts. In Western counterparts, 55 years of age is more common. In India, between 45 to 55. Every year, 130,000 new cancer cases are seen. And it has increased between 1982 to 89. We used to see 11 per 1 lakh population in the city of Bangalore, as per the population-based cancer registry. Today, we know that it is more than 17 to 55 per 1 lakh population. As I told you, not that our women are having a Western lifestyle. Due to other things, we are going to talk to in my future concluding talk. So every woman is a high risk for breast cancer, and she should be made to know education of the breast cancer, how early detection has been made, and she should be given a good quality of life. As I told you, the purpose of all this presentation is we should cure the cancer, give a good outcome of results. They should be useful to the society at large in all forms of life. This is where I am talking to you on breast cancer. Breast cancer, Bangalore is the breast cancer capital many years ago. All of us must have seen Bangalore is one of the highest incidence along with Mumbai and Delhi. And there are various risk factors available to us. I may not be able to identify. Most important thing is some lifestyle changes may also lead to cancer. Some of the communities in India in the past, we used to know Parsi community has a high incidence of cancer. And in some of the major metropolitan cities, incidence of breast cancer is very high, like Bangalore, Chennai, Mumbai, Delhi, and all other places. We all know that you can get the information on any given day. The disease becomes curable if you detect early only. How to detect the breast cancer? The most important thing is always we must bring in on a World Cancer Day or any forum the warning signs of cancer, which educate the women. Today, women can undergo very technology-driven. Women can sit every minute and read what is happening in the Google and other things to acquire their knowledge. It is not the acquired. We should educate them what they should do rightly or wrongly, how it is to be made. Breast cancer, there are what we call as warning signs of cancer. The woman, as I told you, is a high risk for breast cancer. This was the terminology given by the American Cancer Society itself many decades ago. When that is so, the women who has a family history of breast cancer, women who are the high risk group, that unmarried women, people who have taken various kinds of hormones, and some of these are few examples that breast cancer chances may be more than the normal population. Then how to make early diagnosis of cancer? The most important thing is you should, if you are normally, you should try to examine your own breast, because most of our women are very shy to undergo their own examination. They feel that it is very awkward and it is not the right thing. No, your health is important. Health is wealth for you. Unless until you take care of your health, women being an important lady in the household to run their home, she acts as a mother, she acts as a mother-in-law, she acts as a daughter-in-law, every part of the woman. So woman is very important. She should take care of her. Health is wealth is my slogan for every woman. If you don't take care of your health, who will come and take care of you? This is the message we want to give on World Cancer Day, that take care of your health. If you want to tell in the local Kannada language, ನಿಮ್ಮ ಆರೋಗ್ಯ ನಿಮ್ಮ ಕೈಯಲ್ಲಿದೆ, ಅದನ್ನು ನೀವೇ ಕಾಪಾಡಿಕೊಳ್ಳಬೇಕು. Breast cancer, you have to look at the various problems. Any discharge from the women, you should go and show it to the doctor. And any changes in the nipple, or if you find any lump in the breast, you should go and show it to the doctor. As I was talking to you already, if you have belong to the risk factors, if you have got a family history of breast cancer, or you have what we call as corpus cancers, obesity and other things, you should go and get a checkup done. Once you undergo these things, if there is an abnormality, then you must make a diagnosis of breast cancer. How do we make? We make a clinical diagnosis, clinical staging. And after that, once we find a lump, we will do what is called as biopsy. Don't get afraid when your doctor says undergo a biopsy. Biopsy is taking of the tissue to make diagnosis that it is cancer. Like a Supreme Court judgment. Unless until you do biopsy, you cannot call it that you have got a cancer. Histopathological diagnosis is very much mandatory. Today, there is no need to do an open biopsy. We all do guided biopsy. From this biopsy, we can do many other tests also, especially for breast cancer. We call it what is called as prognostication of breast cancer. And we call it a molecular diagnosis by doing ER, PR, HER2, K167, and androgen receptors. This is what we can do, even with a simple blood test. When all these things are available, we'll make a diagnosis, we will stage the disease, plan the treatment. This is how we want to give the message to the people that breast cancer is very important. And today, incidence of losing the breast, nobody should get scared. Today, when we detect it early, gone are the old days that mastectomy was the only thing available to us in 1950s. Today, we have moved from that. When we are in 2015, we do what is called a breast conserving surgeries, followed by oncoplastic procedure, so that cosmetically working women and any woman wants vanity of womanhood is breast. So everyone want to get that preserved. Our main aim is make an early diagnosis, use the combined modalities, preserve the breast, do the breast conserving procedure. And even for the management of the lymph node, we do what is called a sentinel node localization techniques. So that if the lymphedema or arm swelling, which used to happen in the past, has been get reduced. So this is where we use the specialty as developed. After that, as I told you, it's a systemic disease. Combined modalities of surgery, radiation, hormone therapy, and immunotherapy can be given to the patients of breast cancer. And as I told you, every woman should be aware of the breast cancer. You can go to anything in the Google, you will get how to do a breast examination. And I will show you how every woman should be aware of her breast. That is my slogan for you. Periodic, consistent breast self-examination is more important, and every woman should be told about breast self-awareness. Unless until we encourage the breast self-awareness, we cannot make an early diagnosis of breast cancer. And we will show you in some of the pictorial diagrams how everything looks and how we can make a diagnosis. Breast self-examination, you go to any site, you can see, don't feel shy to undergo your own breast examination by standing in front of the mirror and doing the examination. That is very vital. And as I told you, that every woman should stand in front of a mirror and use the right hand for the left breast, left hand for the right breast, undergo breast self-examination. Today, we don't want to see advanced breast cancer. The need of the hour is we have to educate the public on early detection, breast examination. Can we do in this country for the vast population, well spread, the screening programs of breast cancer? Today, we know that we have advanced technology, both in the, as I told you, The combination of engineers and medical doctors, health professionals coming together to develop the technology. As I told you, can we do breast cancer screening? We know that we had a problem in this country. We do not have a well-established cancer screening program. Every non-governmental organization has done the camps and called it an opportunistic screening program, which has done some help, not to the great extent. That is where we are not able to, where organized screening program not able to perform in this country. We are only doing in what we call a smaller sector, small number. The robust data is not available to us. Our main aim today is we have to look at that progress. How can we implement the best cancer screening program in India, which is so fast? And today, though we have a very well developed health system from primary health center to sub-centers to the tertiary care center, not able to do an excellent screening program. That is the problem we are doing. Whom do we screen? Most important thing is every woman at high risk should undergo the breast cancer screening, family history of breast cancer screening, and we had to give them education and ourselves. What have we done all these days? Not that we are not aware of the breast cancer screening. We taught the people breast self-examination, but very few people able to perform correctly. Then we did some of the studies in various working women, where we came to a conclusion, a clinical examination of the breast will help in making an early diagnosis, especially when we have done the various power karmikas and other studies in all parts of the country. A clinical breast examination is very much mandatory. Now we then came a technology development of mammography, and today we got a screening MRI. And as we know that we are in the era of digital technology has been developed. And as we told, we always believe nowadays Indian solutions to Indian problems. What do you mean by that? Use of technology. Bangalore is one of the well-developed technology, software industry, computerization. This is the time where we have to bring in one side the medical health professional, another side the biology people, another side the technologies. This is where we have to try to achieve and do a good breast cancer screening, prevent onset of breast cancer, give a good quality of life. I have been invited by Dr. Geeta and their team. They have developed a technology, what is called Niramai, where they use non-invasive risk assessment and machine intelligence. What do you mean by Niramai? Meaning in Sanskrit, it is the free of illness. The concept is very good, and being the technology developed people, they have developed the non-invasive risk assessment. Nobody can touch the patient. They have understood the human psyche of our women. As I told you, we should get rid of the phobia, understand the psychology. The most important thing in women today is body image disturbances and how utilize psycho-neuroimmunological parameters starting from hypothalamo-pituitary axis. Can we prevent the cancer in a routine homemaker to the working women, bring in the less of trauma and how they can lead the normal life. Ladies and gentlemen, I thought on a World Cancer Day, we are not only looking at the breast cancer screening. Today, we have seen from last 1 year the COVID-19 infection, which has shaken across the globe and brought in some of the developmental program. Adaptations and innovation more important. None of the cancer specialists sat at home because it's a COVID. No. Every cancer specialist looked at the cancer patient, non-emergency thing, they have given treatment to these people. These are the people I call them. They are more COVID warriors. All the health professionals involved with treatment of cancer in the COVID era, that is where they adapted to the situation, followed the guidelines, took all the precautions, gave the treatment to the people, and see over the years, a lot of people are cured and controlled of the disease. This health professional thing, we call it the real COVID warriors. This has not been highlighted. I feel that this is the most important thing. And on the World Cancer Day, our main aim is identify the medical professionals, especially the cancer people, cancer group. You call them onco-COVID warriors. This is most important. This message of onco-COVID warriors should take it forward, bring in the awareness in cancer detection screening program. Cancer is curable if detected early, and early diagnosis of cancer helps in curing it and preserve the vanity of women by doing breast conservative procedure. Thank you very much for your patient hearing. Thank you very much for allowing me to speak on awareness of cancer on a World Cancer Day. And we all should participate and say, I will and I am. That is how the progress in the society can be taken place. Thank you very much, Geeta. Thank you.
Thank you very much, sir.
Yes, that was a very insightful talk, Dr. Gopinath, and especially because you spoke about the whole spectrum. Cancer in general is focused on breast cancer. In fact, as per the latest statistics from Globocan 2020, breast cancer is the most commonly diagnosed cancer, and this is the top cancer overall than both men and women cancers are combined. And like Sir mentioned, it's not because the treatment modalities are not great. We have one of the best treatment modalities being practiced in our country. We have a multidisciplinary team working on it as well. But I think the lag is because, as Sir mentioned, we do not know the warning signs to even pay heed to it. And that is exactly what we're trying to do with this webinar, is spread awareness about the cancer, about the warning signs, about what we should know to be prepared, to be on guard, as is what our next panel is. In fact, our next panel is about the common cancers in men and women and how we can be on guard. And like how Dr. Geeta Manjana did mention, it is not just the physical part of the disease, but the emotional part of the disease, the financial part of the disease. We can go on to the next panel discussion now. Thank you, sir, for setting the context to the webinar. I think it was a very concise, very insightful context that you set for the rest of the webinar. So the next panel, which I have the honor of moderating, I would request Dr. Tanveen to kindly introduce our esteemed panelists.
Hello, everyone. So for the first panel, we have Dr. J.S. Malliga and Ms. Priya Deshmukh, as well as Dr. Monica Suri on board. So as an introduction to Dr. J.S. Malliga, she is a clinician trained in gynecologic oncology, and her work primarily focuses on prevention of cervix and breast cancers. Dr. Subramanian is involved with epidemiological and interventional studies related to these cancers. Her research initiatives and related work involve generating evidence and developing best practices suitable for community-based application in prevention and early detection of common women cancers. She also serves on the board of ICMR's National Institute of Cancer Prevention and Research as a subject matter expert. So welcome, Dr. Malliga. It's really fortunate for us to have you here. Also, we have Ms. Priya Deshmukh Gilbile. Ms. Priya is a seasoned professional and entrepreneur with rich and diverse experience spanning over 24 years in health insurance, healthcare, and ITES industries. In her current role, she is responsible for development and execution of Manipal Cigna's operational strategy, as well as enhancing the service delivery capability and accelerating growth. Her experience spans across operations, strategic planning, sales, business development, and automation. Before joining Manipal Cigna, she held key positions across various conglomerates such as Max Bupa Health Insurance, Cognizant Technologies, United Health Group, GTL Limited, and others. She is the winner of prestigious India's Top 100 Women in Finance for 2020, Mrs. India International 2017 title, All India Golden Achievers Award, Woman of Substance 2017, and also a recipient of several other industrial awards and recognition. She has always believed that we are as strong as we think that we are, and that one has the power to overcome any challenge in life. Uh, Welcome, Ms. Priya. We also have Dr. Monica Suri here. Dr. Monica Suri is a clinical nutritionist and a certified diabetes educator. She's a PhD in nutrition. Her interest lies in devising evidence-based scientific dietary plans. She's a UGC qualified assistant professor and has authored various research papers published in reputed scientific journals and has attended national and international conferences on food, nutrition, and health. She's also the winner of Role of Honor for Excellence in Academics. Her passion lies in educating people on the role of nutrition in primary prevention of lifestyle disorders. A life member of the Nutrition Society of India and various other associations of repute, she has recently completed her certificate in infection prevention and control for novel coronavirus COVID-19 from the WHO, from the World Health Organization. Monica's mission is to ensure healthiness of the populace through scientific diets and healthy eating. So, welcome everyone. We're really glad to have you all here. Over to Dr. Lakshmi.
Thank you, Tanveen. Thank you so much. Good morning, Dr. Malliga, Dr. Monika, and Ms. Priya. It's an absolute pleasure having you all together on this panel, where we talk about common cancers of men and women and how to be on guard. I think probably I'll start off with Dr. Malliga. Ma'am, we've had Dr. Gopinath discuss in depth about breast cancer. Could you please throw more light on the other common cancers that affect women, including their symptoms and risk factors?
Hello, good morning, all of you. Am I audible? Yeah. So I should thank Dr. Geeta of Niramai for giving me this wonderful opportunity to present you people from Chennai. I thank Lakshmi and Tanveer for the introduction. Yeah, that's a phone call. And I should say, I should especially thank for giving me the privilege of listening to Dr. Gopinath's wonderful lecture. It was very people-centric, and he covered all the essential information in a very, what to say, in a very, not in a medical jargon type of way, and where anyone can understand. And he covered all the aspects, all the scientific facts in a very common language and understanding. That was very great. It was nice listening to him. So coming to my question from Lakshmi, so what are the other common cancers? So as Dr. Gopinath mentioned, now breast cancer has taken over uh, um, most of the countries, most of the developed and also developing countries. And if you take India, it is the commonest cancer in most of the metro cities. He also said that it is the emerging cancer in rural areas. Yes. For example, if you take Tamil Nadu, we have a statewide cancer registry in Tamil Nadu. You can yeah, you can on the website the data are available. There are 32 districts, and if you see, almost 18 out of 32 districts top in breast cancer. So earlier, like 3 decades earlier, it was cervix cancer. Not only in rural, even in Chennai. Chennai has been one of the hotspots for cervical cancer, mostly the southern region. But over the years, the reverse has, trend has reversed. That breast cancer has taken over cervical cancer. As he also rightly pointed out, maybe it is the quality of life, but there is definitely the socio-economic and reproductive choices, the lifestyle choices made by women, hormonal. That could be the cause, apart from the various causes, maybe environment, pollution, etc. So the second common cancer is cervical cancer, which is a preventable cancer. So which is amenable to early detection, where we can give a cure, where we can restore the breast, etc. He gave all the advantages of early detection. Coming to cervical cancer, it is one of the commonest cancer which can be completely prevented. So cervical cancer is caused by a virus, human papilloma virus, and there are now tests to detect the virus. There are now tests to detect the disease, like a Pap Smear, that can detect the disease. Then cancer is a oral cancer. So if you take both men and women in India, three cancers: breast, cervix, and oral cancer. These are lip, mouth. We can say that as lip, mouth, and throat cancers. These are common cancers, but which are amenable to prevention. So the third cancer, the oral cancer, is due to tobacco, as you may be aware. So coming to other women cancers, the next which is again emerging as a problem, is the ovarian cancer. And in metros, the ovarian cancer is increasing. Again, it could be the exact reasons are not known. It could be related to lifestyle or many other factors. And the next is cervical cancer. Okay, rightly, you have included a dietitian in the panel, a nutritionist in the panel, because the changing the dietary patterns has um, uh, led to the increase in incidence of colon cancer. It is one of the commonest cancer, top 3 or even top cancer in some of the developed countries. But in India, in both men and women, it has come to the top 5 cancers. So apart from that, as Dr. Gopinath said, lung cancer, even non-smoking lung cancer, is increasing as an emerging trend in women. Then endometrial cancer is also increasing. So the best point of all this common cancer is the common cancers in India. Most of them are preventable or amenable to early detection. Yeah.
Thank you, Dr. Malliga. In fact, I remember when we collaborated in somewhere in 2014 for the cervical cancer screening study. When we were starting that, cervical cancer was the top cancer. By the time we completed the project, breast cancer had overtaken cervical cancer. Yes, so I understand how lifestyle changes, especially, are causing one of the reasons why breast cancer is probably on top. And yeah, there's no denying that one of the most common risk factors are the changes in our lifestyle and diet. With that, I'll take the next question to Dr. Monika. Could you please throw a light on risk factors with respect to nutritional status and dietary intake?
Good morning, everyone. Thank you for having me on board. We all must know that 1/3 of all the cancer deaths are attributed to nutrition and lifestyle, which is alarming. Now, what are the factors or the risk factors which can lead to the cancer? Number one is poor nutrition or undernutrition. Number two is overnutrition, which results in the cases of obesity. So a higher BMI is definitely a risk factor, and there's enough scientific evidence that obesity has been linked to a lot of cancer types. Increase in energy intake, increase in protein intake. These days we hear a lot about higher protein intake diets. The fat diets basically, which focus on more of protein intake. So here I would vary people about, if protein is taken in as much as 2 to 3 times of the required quantity, it can lead to cancers. So in addition to that, physical inactivity has a major role to play. Alcohol use among men as well as women has another major role to play. Now, when we talk about diet per se, there are both the types of components in diet, which the components which are the enhancers for cancer and which are the inhibitors. So here, while we are talking about the risk factors, let us talk about the enhancers in the foods which lead to the cancers. The type of fat which is intaken, for example, red meat and certain type of dairies, they lead to cancers. There are the cooking procedures when we talk about how the food is cooked. The red meat, when it is cooked at very high temperature, for example, grilling and broiling, such kind of procedures are taken. In that case, the protein in the meat, it gets converted into polycyclic aromatic hydrocarbons, which is a carcinogen. So a carcinogen means any factor which leads to cancer. So if we consume it in that form, for example, smoked meat, that is full of this aromatic hydrocarbon. So we all should avoid that. Now, after that, there was a study done by done in Sweden in the year 2003, and they found out that carbohydrate-rich foods, for example, potatoes and bakery items, when they are cooked at very, very high temperatures, there is a substance which is called acrylamide that develops in the food products, which is again a carcinogen. So the type of food, the procedures, how it is cooked, all of this matters. So we all should be wary of what we are eating. And I must mention the genetically modified foods here. They are notorious. Anyways, we all know that they are notorious. So people are resorting to organic farming and organic foods, and we all must be taking care of sorry, the BMIs, the overweight, obesity. These are the main risk factors. And I guess that is all. Soy has been a controversial component, but soy, if taken by the young children before menarche, that has been found to be useful in preventing cancer, for example. But if soy products are taken after around the perimenopausal stages, then there isn't enough evidence which would prove that it is a carcinogen or not. It is a cancer contributing agent or not. So soy is a controversial topic. And otherwise, I've told you, we must take care of the nutrition, the energy intakes, physical activity, and the
Right. Thank you, Dr. Monica, because although we all know what is the right item to eat and what probably is the not so right item to eat, what we do overlook is the procedure, the way it is made. And probably that's why slow cooking is something that our ancestors have always followed. And yes, I think with respect to soy, probably one thing that anything in exaggeration, even protein, too much of anything is probably always a red mark. Yes, thank you. Now I'll now move to Ms. Priya, because despite all that Dr. Malliga mentioned that we have to look out for symptoms, and despite maintaining a healthy diet, cancer can still make its way into our lives. It's inevitable. If it has to happen, it will happen. But apart from the emotional and physical dent it makes, it also makes a financial dent that is less spoken about. And this is often overwhelming. So, Ms. Priya, I would like to ask if a regular health insurance covers for cancer diagnosis and treatment, especially longer duration treatment like chemotherapy, which it's not just a one-time, cost.
Sure, thank you. And thank you to Dr. Geeta and the Niramai team for inviting me on behalf of Manipal Cigna. It's a great pleasure to have heard a couple of my co-panelists as well as Dr. Gopinath. Talking about cancer prevalence and incidence is growing, year on year. And as we know, it's the number 2, cause of death globally. And the incidence in India has grown over the last 2.5 decades. Having said that, a couple of my co-panelists spoke about the risk factors and other elements. Talking about cancer treatment, it's important to understand that cancer can be prevented. 1/3 of cancer can be prevented through small tweaks in lifestyle and nutrition, as Dr. Monica mentioned. But it's also important to understand that technology has developed over the last so many years, and detection has been prevalent, which is a good sign. Talking about insurance and financial security, having a treatment protocol being followed and all of that is extremely important. But cancer, along with the financial burden, brings in a lot of emotional turmoil, a lot of challenges in relationship, the way we engage with the whole ecosystem. So basically, it's extremely important to take that hassle away of being financially secured if at all cancer were to strike you. And yes, of course, insurance covers chemotherapy and all the 3 forms of treatments that are prevalent in treating cancer: pharmacological treatment, your chemotherapy, as well as surgery through various products that we have to offer. So multiple combinations of products are available, and chemotherapy is certainly covered.
Thank you, Ms. Priya. Dr. Malliga, you did mention us about the common women cancers. What are the common cancers affecting men, and what are the symptoms and risk factors of such cancers affecting men?
Yeah. So The top three cancers, as I said earlier, it is cervix, breast, and oral lip throat cancer. So it is the tobacco related cancers are the commonest cancers in men. And until 20, 30 years back, it was oral cancer, like cancer of mouth, throat, etc. Still, it is one of the commonest cancer, but lung has overtaken as the most common cancer among men in India due to smoking and a combination of various factors, the air pollution, and it is also getting commoner in non-smokers. So lung is the leading cancer, followed by oral cancers like cancer mouth, could be tongue, cheek, lip, throat, again related to tobacco. So these are the commonest cancer. Like India is a diverse country with lots of different practices, but tobacco is a common factor. Which is prevalent mostly, especially in northeastern regions where the tobacco related cancers are very high, and it is higher either smokeless or smoking form of tobacco. So especially in southern India, where the cancer due to smokeless form of tobacco, like chewable tobacco, was less. But now we see the increasing trend among the chewing forms of tobacco from young people who are using chewable tobacco, like oral cavity, tongue, lip, etc. So that is really a dangerous trend, which we are trying to intervene at the school level, at the occupational level, not to use those things. So apart from these tobacco related cancer, again esophagus, like Dr. Gopinath mentioned, it is a GI tract. So in some regions esophagus cancer is common, maybe northern belt, or in some districts in southern states also. Cancer stomach is one of the commonest cancer, mostly in the southern state, especially in Tamil Nadu. It comes in one under the top cancers. Then apart from this, as I said, among the top 5 cancers, the emerging cancer is a colon cancer, that is bowel cancer, large intestine cancer, which used to be in the 10th place over the past decade, has creeped up to the 5th place, both in men and women. So these are the commonest cancers. So if you follow these cancers, you can very well understand that it is either due to tobacco or a diet pattern. Um, these cancers, the common cancers, fortunately, so where we can have some kind of preventive intervention, where we can reduce the burden of cancer. Then, as Dr. Gopinath said, there are emerging cancers like prostate cancer is increasing in India, maybe due to men are living long or we are doing more tests, etc. So these are the commonest cancers among men. So if you come to the signs and symptoms, I'll quickly mention the signs and symptoms for women and men cancer, so that I think that is not a separate question in the panel. For breast cancer, the commonest, the whole idea of prevention or early detection is we want to detect the disease before symptoms arise. We will not wait for the symptoms to occur. So basically we advise screening. So for breast cancer, the screening will be like Dr. Gopinath said, it is self-breast examination. All women above 20 years of age should do a self-breast examination. All women above 30 years of age should have a clinical breast examination with their physician or with a trained nurse, etc. And all women above 40 years of age, with consultation of their doctor, should have a mammogram, a basal mammogram. That is the advocacy we do from our Cancer Institute, where we screen the women. So if there is a family history, or if they are very high risk for cancer, then they may have to have more frequent tests. So these before the symptoms appear. So what are the symptoms? So breast cancer starts as a painless lump. So we need not wait for pain to appear. Mostly it is a hard stone-like lump in one of the breast, where there will be no pain in the early stages. Or there could be a lump in the axilla also. So as or a scar or an ulcer on the skin of the breast, or there can be a nipple retraction. So normally nipple sometimes by birth or from the time of puberty, some people may have a chronic retraction. That is not a problem. Any recent retraction of nipple is a concern. And any bloody discharge from the nipple should also invite attention. So they should seek medical attention. Coming to cervical cancer, ovarian cancer, and endometrial cancer, that is the reproductive parts. Cervical cancer, we have screening tests to prevent cancer, but if we wait for the symptoms, it would be usually a white discharge, a bloody discharge, abnormality in menstrual cycles, or post-coital bleeding, bleeding after sexual intercourse. And if a woman has attained menopause and if she starts bleeding, say after 2 or 3 years of the menopause, then it could be a sign of cancer. She should consult the doctor immediately. The symptoms of ovarian cancer are very non-specific. This could include a colon cancer or stomach cancer also. Generally, it will be bloatedness, fatigability, or you feel heaviness in the abdomen, like you feel like something is filling up, like what we say like a gas problem commonly. So you always feel bloated, heavy in your stomach. The abdomen gradually starts distending, and any change in the pattern of passing tools and stools, motion and urine, this should draw attention. So these are common symptoms for ovary, colon, or any abdominal related cancers. So we generally ask people to look for 7 danger signals of cancer. So any recent swelling or sudden onset of swelling in any part of the body, any non-healing ulcer in any part of the body, like mouth or on the skin, or in the near the urinary matters or near the anus. So anywhere if there is a non-healing ulcer, and if there is any bloody discharge from any part of your body, like it could be from your sputum when you cough out, or when you spit, or if you vomit, or from your nipple for breast cancer, or while passing urine or passing motion. And if there is loss of appetite, when you don't feel like eating food for a long period of time, for a significant period of time, and when you find it difficult to swallow food, that we call as dysphagia in medical terms. So if there's a sudden gradually increasing difficulty in swallowing food, if you notice any change in voice or a persistent cough, so these are some of the symptoms which should alert someone. And apart from that, we should also look for specific symptoms, as I said, for a lump in the breast or anything. So rarely there may also be changes in the mole in the body, like a mole starts growing, or there may be a non-healing ulcer in the mole. That should be not ignored. You should seek medical advice at the earliest. Thank you.
Thank you, Dr. Malliga. I think that was a very concise 7 things to look for any kind of cancer, whether there's any change in. Basically, you're supposed to be attentive of your body, of any change that can happen in color, texture, size, shape, or any discharge. Thank you, Dr. Malliga. Dr. Monika, what would you suggest that people should do to be on guard and maintain a diet that is primarily preventive in nature? What are the general guidelines that one should follow, like how we are going to look out for symptoms? What should we be doing with respect to diet?
Very, very good question. I welcome that. Before I discuss the diet, there are certain things we need to look out for. Like we discussed that obesity is one of the major causes of lifestyle diseases, including cancer. So one should be very careful about the healthy weight with respect to the height. So maintaining a healthy weight is one thing. Then second thing is including physical activity in any form, be it yoga, be it exercise, be it walk, be it in the morning or any time of the day. It is not imperative to wake up early in the morning and then do yoga or exercises. One can incorporate half an hour, 45 minutes, or a 1 year routine in the evening or whenever the work schedule permits. Now, third would be the scientific. There is some scientific evidence which states that plant-based diets have been proven to be preventive when it comes to cancer. And as I was talking about earlier, that the diet has got enhancers as well as inhibitors. So here I would specifically like to mention the inhibitors of cancer which are there in the diet. Antioxidants, vitamin A, vitamin C, vitamin E, selenium and zinc. And then we come to carotenoids. And these are all the inhibitors. In addition to that, one should include variously colored vegetables and fruits. Just because they have components which are inhibitory for cancer, which includes anthocyanins, indoles, sulforaphanes, and all are these carrots and bell peppers, yellow orange fruits. So all of these products should be included. As per the guidelines, one should include 5 to 7 servings of fruits and vegetables in a day. Yes, these are the guidelines. So I am very sure people are not even taking once or twice. So that is wherein we fall into the danger zone. Increase in the fiber intake in our daily routines. When we are talking about the dietary pattern and the routine we, as an Indians, we follow, we intake a lot of processed foods, which is not high in fiber. And specifically the diets which are rich in proteins, they are low on fiber content. So we should include a lot of fruits, vegetables, and cereals, the whole cereals and the whole pulses, so that the fiber intake also goes high. As Dr. Malliga mentioned about esophageal cancer and the oral lip and the mouth cancer, there was a study done a few years back which stated that intake of very hot liquids or very, very hot food was one of the reasons for these kind of cancers. So maybe one can avoid taking very, very high temperature foods and have it at a little lower or a moderate temperature. That would help. Now, low salt and low fat. As earlier I mentioned, red meat and certain types of other meats and dairy and saturated fats have been found to be contributing factors for initiation of the cancers. So any diet which is low in salt and low in fat, and all of these processed foods are very, very high when we talk about salt. So we should be avoiding all the processed foods, and there are a lot of preservatives in the processed foods. There are a lot of additives and the preservatives which should be avoided. And in addition to that, if I have to mention low fat, as in one should calculate the total amount of fat, the fiber, the carbohydrate, the proteins, and everything as per the height and the weight. So any sudden increase in the weight can be a reason of concern, or any sudden decrease in the weight can also be a nutritional symptom of catching any of these diseases. Dr. Malliga mentioned a lot about all the clinical symptoms, but a sudden decrease in weight, more than 10% of decrease in weight over a quarter, or more than 5% decrease in weight over a month, is contraindicated. And here I would also suggest people not to go in for fat diets or crash diets and look for sudden and immediate weight loss, because ultimately these are the things which backfire somewhere or the else. Our human body is such that we do not know what is going inside. There are a lot of metabolic processes, the biochemical reactions which are taking place. So we do not know, and many of these factors have got overlapping, things which are not even easy for a nutritional scientist to, because any diet wherein we reduce the red meat and the fat content, then there is a corresponding decrease in the animal fat in the body. So ultimately, the outcome of the study gets affected, because that becomes a co-founding factor, right? So in addition to that, as you mentioned, slow cooking can be a better alternative, and no alcohol. Alcohol should be restricted as much as possible, both among men and women. So these are the major guidelines for all of us who have not been detected. So when we talk about primary prevention, so these are the steps one should, these are the things one should keep in mind.
Right. Thank you, Dr. Monica, and especially, I think, yeah. So, from what if I could take out two lines from what you mentioned, I think it's to have a very colorful diet, have a lot of orange, red, yellow, green in it, and if people are wondering how do I decide which is packaged, which is processed, anything that you buy out of a counter which is sealed in a cover and says 5% this, 10% this, 13% this, you know there is something that you should try and avoid as much as possible. And I know there are so many things that are available in colorful packets which you can't. So please go out and exercise. I think it's a balance. You can't just say, oh, I'm going to eat healthy, but I'm not going to exercise, or oh, I'm exercising, I don't have to eat healthy. I think they go hand in hand. Thank you. Ms. Priya, the next question for you is, as insurance providers, what are the products that cover high treatment costs? And what is that one package that every person should have that will guard us against all kind of financial nightmares? Because if I have to go buy a package for cancer, for diabetes, it might be difficult to even keep track. So if there is at least one or two packages, if you could speak about it.
Sure, sure. Thank you, Dr. Lakshmi. Good question. And just to reflect, with the incidence going up, it's important for us to prevent cancer, kind of invest our energies in right nutrition, as well as early detection, and avoid the instance of, being in the state of having cancer. But having said that, if at all, cancer strikes in, it's important for us, as we earlier discussed, to have financial security and the mental, security, so to say, to be treating at the right, facility and not getting worried about the financial burden, right? So primarily, as we all have discussed, that there are three stages or three protocols to be followed in cancer treatment, which is pharmacology, which involves chemotherapy, targeted therapy, hormone therapy, and even immunotherapy, so to say, and a lot of advanced treatments that are coming in, the radiation therapy and the surgery. So it's important to really see how insurance product really covers everything comprehensively from a treatment perspective. Also important to really have insurance products which help people, kind of encourage people to diagnose early, or rather to prevent diagnostic testing and ongoing tools that some of our co-panelists mentioned about. So there are various kinds of products from an insurance perspective. One is called as the indemnity product, which is hospitalization cover. It ranges between 5 lakhs to up to 3 crores. Many insurance companies offer, there are certain products which go up to 6 crores, because cancer and certain types of aggressive cancers would need a lot of care, and the expenses could be really tall. And nowadays, a couple of companies like us, Manipal, Cigna, we also have coverage and treatment options globally. So you may want to choose such kind of products which give you, if at all you choose to really get, center of excellence, maybe worldwide, or top countries, you could travel and get the best in class treatment. So up to a sum insured, the indemnity product. There's another type of product called as critical illness, where if at all cancer strikes in, there's a lump sum benefit or value of money, sum of money that is given to the patient, the member, which not only helps the patient to take care of the financial treatment expenses, but also any loss of pay, any kind of child care, any kind of incident, so to say. So that kind of a critical illness products are also available. There are certain products which also offer diagnostic testing, like cervical testing, and you have mammogram, as one of our members mentioned, and vaccination as well is covered from a preventive and diagnostic treatment perspective. But it's very important when one is making a choice. Not, as you rightly mentioned, you can't have cancer specific plan, and then you have all the other diseases, and it's very difficult for someone to really predict, so to say. So it's good to have a base product which is very solid and comprehensively covers preventive and vaccination kind of health and wellness, annual health checkup kind of a feature. Then you have a base sum insured covering all other diseases and also cancer. And also important for us to consider that the value of the sum insured. We can't really say, oh, I have a 2 lakh, sum insured for annual, coverage, and maybe a couple of members also as part of the family floater kind of a product. Then you have insurance for the namesake, but it's very, very, kind of minuscule for you to cover the expenses that cancer brings in as part of the treatment. Because once diagnosed, following diagnosis, for the first 2 to 3 months, the expenses are going to be very, very high. It will involve a lot of treatment protocols to be followed, and hence it's important to really be very smart in identifying and buying the right insurance cover at the right age. So we have instances, in Manipal Cigna, our endeavor is to help people live healthier, happier, and more successful lives, right? So we do endeavor to give that mental peace to our members. So we have instances of very young age members having suffered cancer, like leukemia and a couple of others. And we have really supported, year-long, 2 years treatment. So on an average, we've paid almost 60 crores worth of, cancer claims over the last 3 years, 3.5 years. So you can imagine the prevalence, and you can imagine the amount of cost, and the aggression with which cancer can really disrupt a person. Because once hit with cancer, it may disrupt the entire family structure, the way the earnings are, and hence it's important to have the right cover, which is comprehensive, and the right value of the cover along with the riders is what I would suggest.
Thank you, Ms. Priya. I made notes too. I wrote down points from your talk as well. And like you said, I think it's very less spoken about the financial part of it, because everyone believes, and somehow everyone believes cancer will not happen to me. It happened to my neighbor, to my relative, but not to me. And hence we forget that we need to be financially prepared as well. I think that was very helpful. Thank you. Dr. Malliga, you did mention the symptoms of men and women cancers and what are the risk factors and all of that. But if I have to go today and say I'm going to get a health checkup done every year, like we do for diabetes or hypertension and thyroid, what are the mandatory routine tests that a man or a woman should undergo for screening of common cancers, and how often should they get them done, like as a general person?
Yeah.
Without any high risk factor.
Yeah. So it is for the general population, irrespective of the risk. So I will start with tobacco first. Quit tobacco. So before going for any screening test, if you are a tobacco user, quit tobacco, because you are at reduced risk of 50% of cancers if you quit tobacco. And try to quit alcohol. If you're a severe user, bring down to moderate. If you're a moderate, bring down to mild, and so on. So better avoid it. So because alcohol has been, as Dr. Monika had already mentioned, alcohol. Apart from that, awareness. So be aware of your body. Like, for example, self-breast examination, watch for symptoms and signs. Apart from this, we have specific screening tests where we can prevent or early detect cancer. So I'll start with breast cancer. Awareness to do self-breast examination once a month, and a clinical breast examination once in a year or once in 2 or 3 years based on your age and risk. If there is a family history, if there's a very strong family history, like your close relatives are affected, then it may be an every year screening. So once you cross 40 years of age, we generally advise mammogram, which is the X-ray of the breast. For if you do a self-breast examination and detect a lump, say a painless lump, then you want to see whether it could be a cancer. So don't panic. You first have to do an imaging test. So you have to consult a doctor without delay. And if you're less than 40 years of age, an ultrasound breast scan will be done. And if you're above 40 years of age, a combination of tests are done, like mammogram, ultrasound, and if there are any special indication, an MRI can be done. So as a clinician, when we are advocating this, like women have myths about like mammogram, it is painful and all. That apart, as a clinician, I was very excited when I was introduced to this Niramai, a non-invasive technique, which if it can be applied to large mass of people, where we can detect even before a lump is formed. So mammogram that way helps, but unfortunately, like Dr. Gopinath said, still such facilities are not available even for diagnosis in many parts of the country. So from a person point of view, from a woman point of view, she should be aware of her body, self-breast examination, clinical breast examination, breast imaging studies as per her age and as per medical advice. Then coming to cervical cancer, which is again a common cancer. So any sexually active woman is at risk for cervical cancer. So like Dr. Gopinath said, any woman is at risk for breast cancer. Any sexually active woman is at risk for cervical cancer. So any woman who is sexually active should undergo some screening tests. So the commonly available screening test is the Pap smear. Your gynecologist will take some fluid or some tissue. It's a very not a painful thing. Just draw a swab from your cervix and she will send it to the lab. And if there are any abnormal cells, you are going to get treated and the cancer is prevented. This is the only cancer where you can prevent apart from tobacco related. And there is one more test, a HPV DNA test. I said virus causes it. So you detect the virus. And if the virus is there, then you look for the disease. And if disease is there, you treat it. So before it develops into cancer. There, apart from this, there are also a couple of tests called visual tests, which is available in all public health facilities where women can't afford the other tests, or if there is they don't have access to the tests, which these tests are unfortunately in India still available in metros and larger cities. So even in rural areas, in the primary health center, through the central government health initiative, the screening is available. So just an examination of a cervix will help us to prevent or early detect cancer. So these are the two main cancers for women. Apart from that, oral cancer, which is very common, we can do a self-examination. Just if you're a tobacco user, look at your mouth. Even if you're a non-tobacco user, especially older people who are using dentures, or sometimes there may be a sharp tooth which chronically irritates and that may cause a non-healing ulcer and that may lead to cancer. So you just, tobacco users, they should definitely examine their mouth, and if they see any white or red patch, they should, that is going to become a cancer. So you stop tobacco and consult a physician. And anyone who has a sharp tooth or an ill-fitting denture, get it set right with the dentist. So these are the common things. So for ovary, unfortunately, we don't have a very a specific or a proven effective screening test. But post-menopausal women, they are advised to undergo an along with their master health checkup, they can undergo an early ultrasound of their abdomen that may help them. For lung also, we apart from quitting tobacco, we don't have a specific test, but if there are any suspicion on a routine chest x-ray, you may be advised to undergo a CT scan. And for other cancers like esophagus or colon cancer, so if there is a recurrent gastritis, like we all say ulcer problem and we ignore it. So if you have a dyspepsia or like you keep on belching, or if there is a regurgitation, acidity, then you better consult a physician, and there may be an upper endoscopy which can early detect cancer. For men above 50 years of age, if they have a family history of colon cancer, that is large intestinal cancer, then they can undergo stool test. They can just submit their motion for test, and if there is occult blood, that may not point towards cancer, but that will lead to further tests to rule out cancer. If there is any bleeding per rectum, or if there is a positive family history of cancer, or if there are any other symptoms, men can undergo a colonoscopy where they will examine the rectum. Through the anal canal, a tube will be introduced, and these are all based on their risk factors like a family history, or if they are passing motion tools, or if there are any other symptoms regarding that. So for prostate cancer and ovarian cancer, there are also biomarkers like CA125 ovarian cancer, but it is not specific. So without a medical advice, you need not go unless there is a suspicion. The doctor will advise CA125. You can go for that. For PSA. it has again not a very it is again an ambiguous test with a medical advice, and if there are any symptoms like urinary symptoms, the doctor will advise a local examination or a scan through the rectum, and also the serum PSA levels. So this may indicate. So remember, these tests are to screen you whether you have any early diseases. So being aware of the signs and symptoms, and aware of the these common screening tests based on your risk factor will be the way forward. But any woman above 30 years should undergo screening for cervix and breast cancer, because it is very common. And it is very, very, very commonly available. Like all the health facilities are now providing the screening facilities. So it is a preventable and early detectable cancer. We should not miss the opportunity. Thank you.
Right, right. So yeah, breast, cervical, and oral, I think it's the top three cancer, easily preventable, easily treatable, easily noticeable. I think, yeah, so these three we cannot give excuse for not getting them in. Thank you, Dr. Malliga. Dr. Monica, you did tell us how diet could play a preventive role, but when a person is diagnosed with cancer, the diet may require modification. Could you throw light on such dietary modifications, and why such modifications are necessary in the first place?
Very, very, very well put question. Dietary modifications are required. The dietary guidelines before diagnosis and after diagnosis, they do differ. Number one. Before diagnosis, guidelines we've already discussed. Now, when we talk about once the cancer is detected, now there are a lot of symptoms that a person feels, as Dr. Malliga also mentioned, loss of appetite, and then loss of taste. And before discussing all of this, the symptoms a person feels or comes across, I would like to mention that once the cancer is diagnosed, as Dr. Gopinath said, we should not panic. We should not panic, because early detection of any cancer is curable. Now, if a person panics, comes under stress, the cortisol levels go high, then even if a person is following the dietary guidelines, it will not give the desired results. So number one, keep the stress levels at bay. Now, once the cancer is diagnosed, then there are different stages. Initiation, and then there is a progress, and then the promotion, and then the progression. Now, dietary guidelines differ according to the stages of the cancer, but there are certain common features at all the stages which a person has to face. Loss of appetite, anorexia, depletion of nutrition stores. The weight might go down rapidly. And all that weight which goes down is basically your the muscle mass which is going down. It is never a fat loss. The muscles they get degenerated because there are alterations in the metabolism. The metabolic rate, depending upon the stage wherein a person is in, it can be normometabolic, it can be hypometabolic or hypermetabolic, and in most of the cases it is hypermetabolic. So here the requirement, the basic needs of in terms of the energy, the calories, the protein and the carbohydrates, it goes up. So we need to assess the person. The screening and the assessment of the person is required before we give in any of these guidelines. But because of weight loss, wasting, weakness, basically protein energy, malnutrition, anorexia, a person needs a lot of calories and a modified diet. Secondly, when a person goes in for treatment, whether a person goes for chemotherapy or radiation or hormone replacement therapy or hemopoietic stem cell transplantation, in all of these cases, the immunity of a person gets suppressed. So this immunosuppression makes a person very, very prone to upcoming infections. That infection can be through any of the agents. So when we talk about diet, the person should not be intaking any raw or semi-cooked food or half-cooked food for that matter, no processed food or because for example, a plate of salad, the raw salad will be very, very high when we talk about the bacterial load. So that should be avoided. and in fact that should be eliminated from the diet. Then there are a lot of abnormalities in the electrolyte and the fluid balance in cancer after the cancer detection. So we may have to monitor the fluids and the electrolyte over the days, weeks, or maybe months. Then this has to be an ongoing process, because fluids are very, very important. And then once the cancer sets in, there's a lot of metabolic change. The carbohydrate metabolism, the protein metabolism, everything gets affected, and also the electrolytes in the body. So all of this needs to be taken care of. And now in the initial stages, a person may be able to take the food orally, but loss of taste is a major hindrance. Then the texture of the food, that needs to be modified depending on the person's preferences. Maybe as Dr. Malliga mentioned, the person may not be able to swallow the food, so dysphagia. So dysphagia is another hindrance. So we need to modify the texture. We need to give a semi-solid or a soft or a mashed food. Then there is a hypening in the sense of smell. So a person may feel an aversion to the food which has got a very sharp smell, or even if the smell is the food aroma is normal, but that heightened sense of smell may irritate the person. So therein we need to modify the diet again. In addition to all of this, when the cancer progresses, suppose a person is detected at a very late stage, in that case, if the person is not able to have enough food, loss of appetite would anyways, then there is bloating. Dr. Malliga has clearly mentioned bloating, burping. So a person is not able to have enough food orally. So in that case, we have to go in for either enteral or parenteral nutrition, depending on the clinical status of the patient, whether an oral support is required, or a person is able to have normal food or not, even if it is semi-solid. Even if a person is not able to have a semi-solid or a liquid diet, then we have to put the person on the parenteral or enteral feed. Overall, the general guidelines, when we do the calorie calculations and everything, has to be in place. In addition to that, the diet should be rich in complex carbohydrates, as we talked about the fiber earlier. It has to have adequate proteins, because if the metabolism has got altered towards hypermetabolism, hypermetabolic activity, then the protein needs have to be supported. A person with the cancer is basically catabolic. It drains out the nutrient stores of the person. So the protein requirement can be as high as 2.5 or can be as low as 1.2, which is normally 0.8 to 1 gram in a healthy adult. Low fat, and most importantly, low oxalate diet. Oxalates should be reduced in the diet, and lactose free. Multivitamins we need to supplement in the diet, specifically vitamin C, A, and E, because these are antioxidants. A lot of research is going on about the efficacy of vitamin C, and no definite, cure has been found out of this thing, but all of these antioxidants and the phytochemicals in the food have been found to be proven for preventing, definitely yes, and for reducing the intensity of these symptoms that one faces. So there's no need to panic. We have guidelines and the support for the people at every stage they are at. And a calculated diet, obviously a person would be under a trained qualified nutritionist. So things can be taken care of.
Thank you, Dr. Monika. I think it's a very difficult balance to achieve, saying that, okay, the cancer cell, cancer body that has cancer requires so much nutrition, but at the same time, it's not able to take in all the nutrition that we are feeding. Even physically, it's not able to take, and it's not able to absorb the nutrients. So it's a very difficult balance that we are trying to achieve there. So all the audience out there, if you're listening to this, let's not take it to that stage in the very first place. Let's not put our body through some abuses. Let's try and have it at the preventive, and hopefully not get to the stage where we're trying to strike that very difficult balance. Thank you, Dr. Monika. Right. Ms. Priya, I think the final question to you is, in a scenario where a cancer patient has insurance and wishes to renew it, what does she have to keep in mind? Would such a renewal be allowed? Because there's so many myths about insurances. So please answer this, as well as if there's any one myth that that surrounds insurance and renewal. Please try and help break that myth for us.
Sure, sure. Good question, and take this opportunity to kind of burst myths around insurance products and cancer treatment. So first and foremost, before I come to the primary question that you asked, Dr. Lakshmi, most of the private insurance products cover cancer from day one. There is no waiting period and there is no capping. So most of the products, so choose the product very, very wisely, look through the details of the product because it's extremely important. Second thing, people have this myth that chemotherapy and radiotherapy, if one were to avail it, normally insurance product, there is a myth that one has to be in hospital, or rather 24 hours hospitalization is a must. But that is not the case. The newer products allow daycare basis chemotherapy and radiation treatment protocols to be followed without a need to be, in the hospital for the ease of the customer, ease of the patient, so to say. The advanced treatment and the oral therapy and the adjuvant, advanced modern treatment protocols have now been included from 1st of October 2020, wider regulatory, kind of mandate, and hence all insurance companies cover the modern treatment and the oral therapy for cancer treatment. And one more thing that I would like to touch upon is people normally ask this question to me that if someone is not having insurance and gets kind of diagnosed with cancer, then is there a possibility of some financing and some support coming from insurance? Insurance is about risk pooling, and typically healthy lives are given insurance, and then that's what funds the people who really suffer from any ailment, leave alone cancer. There is one product in the industry which is run on the pilot basis currently, where up to a 5 lakh, very small, sum insured basis, one insurance company is offering insurance coverage for people who are diagnosed with cancer, but in the stage 1 and stage 2, from 5 months of age to a 65 years of age. But the layer of insurance is very small, up from 2 lakhs to about 5 lakhs. So my advice would be to buy insurance early on, not only for cancer, but take away the, one cannot, once kind of diagnosed with cancer or any ailment, one cannot take away the pain associated with going through the whole process. But at least the financial security and the mental peace is something that is in our hands. So it's important for us to really plan ahead of time and really, kind of get the right product for us and our family members. So that's what I would advocate. And most importantly, the question that you asked, once diagnosed with cancer, and if the person, the member, the patient has insurance policy, will it be renewed? The answer is yes, because as an insurance industry and as Manipal Cigna as well, it's a moral responsibility to really be there for our consumers and our members and people who are patients, so to say. So even if you're diagnosed, even if there is a treatment that is going on or has gone through, your policy will be renewed, and the terms and conditions and the benefit will be restored and will be continued, is what I would like to say and assure members, so that we can build trust in the patient community as well as the physician community and the insurance, because it all comes together. It really fits in well, is what I would say. So thank you.
Thank you, Ms. Priya. That was very comforting to know that, once diagnosed and once, if we have made the planning much ahead to have an insurance, it will still be renewed, and, we can trust the insurance that way. I have not probably emphasized more on this, but as students in the medical college and in a very, very juvenile way of talking to patients, we have actually scared them with the treatment cost to quit tobacco than anything else. I know that has worked more, for them to quit the habit, because they're usually of not too well-to-do means, and treatment is something that not all of us can afford. So yes, insurance is very important to all the audience listening to us. Have a very healthy diet. Preventive way is to have a healthy lifestyle and diet. And once, look out for your body, look out for the changes, look out what the body is trying to tell you. Try not to abuse the body, listen to the body. And third, make sure you have planned ahead and bought the right insurance, because health costs are a major cost in our lifestyle, which we do not consider. So yes, so prevention, like Dr. Geeta mentioned, it's better, cheaper, and easier than cure. So please focus on prevention. I just realized that the all three panelists are women, so it was a great pleasure hosting this panel of all women, by women, but not necessarily for women, it's for all men and women. Thank you. It was a great pleasure. Thank you, Dr. Malliga, Dr. Monika, and Ms. Priya.
Thank you very much. It was a great honor and pleasure.
I will now request Dr. Geeta Manjuna to take over for panel 2. Before that, Dr. Geeta, do we have time to play a 2-minute video regarding the symptoms of cancer? Because I think it will summarize what Dr. Malliga did mention now.
Sure, I think that will be a great idea. And meanwhile, I request all the panelists to get ready with their videos on. Yeah, please go ahead.
Panel to panelists. Dr. Tanveen, can I request you to share the 2 videos? I think that would be a great summary of this present panel that we just had.
Sure.
Dr. Geeta, we have one more very similar clip on common cancers in men. That will also is less than 2 minutes.
Yeah, maybe we can play that after the second panel. I think
Sure,
that.
sure. Yeah. Okay. Yeah. Thank you. Over to you, Geeta. Yeah.
Sure. So again, that was a wonderful panel of specialists looking at cancer care. Thank you very much, Dr. Malliga, Priya, and Dr. Monika for that excellent sharing of thoughts. We now look at how do we make cancer care or cancer screening possible to everyone, making it more affordable, accessible, and make rural screening of cancer possible, right? And for this, we have really 3 great experts who have spent almost all of their career trying to serve this community. And so I'll request Dr. Tanvi to introduce each of these panelists, but to just sort of bring them on board, request Dr. Vinny Srivastavji from Japago, Dr. Balu sir from JJMMC, very renowned community oncologist, and Mr. Suresh, Vice President of Karnataka Cancer Society, who's an excellent partner of Niramai as well, to come on board and enable that video. And Dr. Vinit, maybe we should just start with Dr. Tanvi giving an introduction, please.
Hello. So as Dr. Geeta mentioned, we have 3 excellent panelists again for the panel 2 discussion. Dr. Balu heads the Department of Community Medicine at JJM Medical College and Hospital in Davangere. Has an MPhil in Hospital and Health System Management from BITS Pilani. He holds many prestigious positions such as Chairman, State Task Force for RNTCP, Karnataka, Vice Chairman, Zonal Task Force South, RNTCP, and President, Association of Public Health Technologies. He has also contributed immensely in the development of training modules in the areas of HIV/AIDS, tuberculosis, and sexually transmitted diseases. He has been awarded the prestigious Shri B.M. Patil Oration Award in 2017. His special areas of interest include application of digital health technologies in public health and its implication in healthcare delivery system. Welcome, Dr. Balu. It's really good to have you here. As Dr. Geeta also mentioned, we have Dr. Vineet here from Japago. Dr. Vineet is a public health professional with more than 20 years of experience in strategizing and implementing large-scale public health programs related to reproductive, maternal, neonatal, child health, and adolescent non-communicable diseases. During the association with Japago India, he oversees the design, implementation, monitoring, and evaluation and quality of NCD programs on women's cancer, which are also cervical and breast cancer and gestational diabetes mellitus. He has spearheaded development of NCD portfolio in Japago. He's a medical graduate with an MBA in healthcare management and a master's degree in public health. Prior to joining Japago, Dr. Srivastav has served some of the most reputed national and international public health organizations, namely PATH, UNICEF, WHO, and the World Bank Adyar project. Welcome, Dr. Vineet. We're really fortunate with given your experience and your journey. I think it will be a good discussion going forward. Mr. Hpv Suresh from the Karnataka Cancer Society, he finished his graduation in pharma and has rendered his voluntary services to Karnataka Cancer Society for more than 28 years in various capacities and continues to be passionate about his cause. Currently, he is serving as the Vice President of the Karnataka Cancer Society for a post that he has graced since 2014. It is our greatest honor to have you as our esteemed panelist, sir. Over to Dr. Geeta.
Yeah, thank you, Dr. Tanvi. And welcome once again to the all-male panelists here to talk about the process issues and challenges on the ground when we try and take this solution to people who actually need it the most, right? To start with, I request Dr. Balu sir to throw some light on what do clinicians think about this problem? You know, coming from a medical college, like a very famous one in Davangere, the JJMMC, and you've been in the community screening on oncology and tuberculosis and all of these specializations so far, sir. How do students of medical colleges think about this community screening? Is it part of their syllabus? Do they really have to go to villages and screen? And what exactly, for example, a community screening department of JJMMC would do, for example? Right? So if you can just sort of give us an indication of how it is in a community medical college.
First of all, thank you for having me here with such an esteemed panel with so much experience in oncology. Just want to throw some lights, you know, before I go into the student involvement as such. The efforts which were made by RGHS, which is our parent institute, I remember a few years back, I think maybe 8 to 9 years back, Rajiv Gandhi University came out with this concept of, setting up cancer case cell in medical colleges. If I'm not wrong, they started looking at piloting in 2 districts. One was Chitradurga. I don't remember the other one. So the efforts have been in place since few years from the university side to bring in, the focus back on how do we, develop a cancer care model in the colleges. As recently as 2 years back, the university had a meeting, and they have now set up a cancer registry attached to all the medical colleges. The focus is coming back on how do we set up a cancer care center in the medical colleges. Coming back to your question on, are students exposed? Are colleges involved in community-based screening? It is most difficult question to answer. Let me tell you why. Because in a medical college, it's a tertiary care center, and when I look at each medical college has its own different infrastructure in place.
Yes.
So yes, when we look at our own community medicine department, we have our rural centers, but I don't think there is a specific focus on, I go and do exclusive screening clinics for cancers. I can say we have something like a missed opportunity, if you ask me. Medical colleges definitely do a lot of camps, but unfortunately, unless the woman or man coming there says he's having some problem, I think we are not going to pick it up. That's my observation from my own experience of doing many camps, including we were lucky enough to have implemented both the World Bank funded and state funded NCD projects. Second thing, when I look at training, to the medical students, students are exposed to only the clinical management. Okay, that too partially. Students are not exposed to a comprehensive cancer care management. I was very impressed with the previous session where there was so much information we got on diet. I think when I look at a medical college concept, student, yes, they may be exposed to the clinical management aspect, but not the continuum of care, what we call, or a palliative care, which I feel is not existing in most colleges. I am sure of at least 70 to 80% of the colleges may not be having the palliative care, because even many medical colleges refer the cases to the next center. So in that sense, I don't see a structured way of doing screening clinics in the outreach. Although colleges are doing it, the focus may not be on the cancer. Yeah.
Yeah, I think that's very, very helpful, especially when you say missed opportunity. It gives me a little more hope that, we can actually, one is also the mindset of, clinicians and new doctors who are coming out to sort of try and look at it like a universal platform rather than CT only platform and more. So we'll discuss more about, how do we make this happen as we move on. So moving on to Dr. Vineet, Jhpiego, is known to some part of India, and there is so many other people. For example, I came to know about Jhpiego only about a year ago. So can you tell us, like, what is Jhpiego and what are the kind of programs that you run for screening? It's amazing to see so many awards and so on, and you work with Bill Melinda Gates Foundation and so on. So Dr. Vineet, and what exactly is your role, especially as head of women cancers screenings, and what Jhpiego per se does? Dr. Vineet.
Thank you, Dr. Geeta, and I'm really happy to be part of this esteemed panel. And this is really one of the most important topics which needs to be covered, and it should be the next priority. It should already be a priority, I would say. So let me try to introduce what Jhpiego is and what we endeavor to do. So Jhpiego is an international nonprofit health organization which is affiliated with Johns Hopkins University. We had been working in public health area, empowering frontline workers by designing and implementing effective, low-cost, hands-on solutions. Getting in process solutions in place for quality delivery of healthcare services for largely for women and families. Uh, we have been working globally in more than 155 countries for last 40 years, and our key areas had been focus area had been improving the clinical competencies of the various level of providers. When I say clinical competency at various level of providers, as we all understand that every level of providers has a unique responsibility. And to deliver that unique responsibility, he requires a different kind of competencies. So identifying those competencies, demystifying them, and providing them to in a very simplistic manner. That is one of our key, I would say, expertise area. We have been working in various areas for improving women's health, which also includes breast and cervical cancer. In India, we had been working since 2009, and one of our prime area of work is for women's cancer, integrating breast, cervical, and oral in alignment to the Government of India initiatives across 14 states, with targeting over 50,000 health and wellness centers, which have been newly constituted under the Ayushman Bharat. So I'll stop here. So this is what we are trying to do. The next step, I would like to just speak some more. As Dr. Balu very well said, that currently the cancer care in India is being looked at with the lens of clinical management. But as we all know, if you look at the continuum of care, from awareness generation, mobilization of these population, high-risk population for the screening because they're healthy women, and imparting those screening services, making them available, quality services available, is also one of the most critical components. And that's where public health comes in. So if we actually want to address the burden of cancers in India, the public health and the clinicians would have to come together to come up with a solution.
Absolutely, well said, sir. So, and we'll come back to what are the current challenges in that, after we get to hear from Mr. Suresh as well. Welcome, Suresh, sir. I mean, it's been a pleasure to be working with you for the last 3 years, trying to take breast cancer screening to villages and talukas in and around Bangalore. So, as Vice President of Karnataka Cancer Society, maybe, I mean, I've been part of many camps, and first time I ever saw rural India is through Karnataka Cancer Society, and how these women can actually be so easily convinced to go through this screening as such, and so on. So, so how do you manage to do that? What does Karnataka Cancer Society as such does, Mr. Suresh? So, if you could educate everybody else about what is KCS and what are the programs, please share.
Thank you. Thank you very much for giving us an opportunity. On behalf of Cancer Society, I'm going to thank you, madam. Karnataka Cancer Society is an NGO organization established in 1968 by the dedicated, eminent stalwarts like Dr. Shivram, Dr. Gurudas, Dr. Sirsi, Dr. Krishna Bhargava, former director of Kidwai, Dr. M.S. Anantraju, Savitrama, N.R. Acharya, Captain Timapaya, Dr. B.S. Srinath. Can you hear me, madam?
Yes, we can hear you, sir.
Captain Timapaya, Dr. Shastri, Dr. B.S. Srinath, Dr. Vijayalakshmi Deshmane, one of the famous breast surgeon and former director of Kidwai, and of course, Nafis Fatima. Our main intention is to give awareness, prevention. We do a lot of, hello?
Yeah, there's some disturbance in the audio, sir. So, but yeah, please continue, sir. Let's see.
Okay. Our main intention is to give awareness about cancer and prevention and also detection. We do a lot of camps in and around Bangalore and all over Karnataka. Especially, we are concentrating on 3 types of cancer, that is breast cancer, cervical cancer, and oral cancer. See, in olden days, it was very difficult to have the cancer screening program because the people, they used to get fear to come for the camps. After some times, we have convinced the people and we have given lot of awareness talks. See, previously it was telling once a patient gets cancer, it is cancel. Now it is not like this. Latest technology has improved like anything. And one more thing I want to tell you is cancer is curable if detected early. So our main slogan, we are running with the main slogan, cancer is cured if detected early. Now the patients are coming voluntarily. And of course, I want to thank you and your team because you are very closely associated with Cancer Society, and we are doing a lot of breast screening camp all over Karnataka, and people, they are very happy because the technology what you are used, it is a non-invasive without touching the patient. They are very happy and they voluntarily come. And of course, Cancer Society is doing a lot of camps, especially in second Saturdays. We are doing camps totally free. That is thermal mammogram, Pap smears, and oral screening, madam.
Okay. So that's very nice. Yeah, I mean, like every second Saturday, if you see any maid or anyone who cannot afford, even inside Bangalore, right, please direct them to KCS. It's in a very hot location and they can just get free screening. And that's something that all of us who are listening can definitely do, especially if you're in Bangalore. And I'm sure similar, efforts will be there in other cities. Please let us know and we will create awareness on it. Thank you very much, Mr. Suresh, for that. So now let's get into sort of, what are the problems that exist on the ground and sort of brainstorm on how we can try and solve it, and can we have some solutions and so on. So I'll go back to Dr. Balu sir and then say, okay, you've done many community screenings and also many community screening trials, sir, actually. So to prove, because it's not just enough to conduct screening, the results of screenings also have to be correct, whether it's done in hospital or outside, it has to be correct. So what are your thoughts and what are your learnings and experience nuggets that you can share, Dr. Balu sir, about conducting, let's say, clinical trials of these community screenings, community outreach programs, and what are the challenges you face to conduct these trials or conduct these screening programs, Dr. Balu sir?
Yeah, I'm very happy to learn from Mr. Suresh that people are accessing voluntarily the camps. It is a good sign. I really congratulate them for the work they are doing. I think that's the difference what NGOs and makes when compared to the camps we do from the colleges or the programs we do from college. Let me share some of our experience of implementing some of the community-based projects. We implemented and supported the World Bank funded NCD project in the state in 2 districts. One is Davangere and other one was Mangalore, which was taken as a pilot. The whole difference there, which they were looking was, can we take the NCD clinics up to sub-center PHC level? That's what is being practiced in Tamil Nadu. So Karnataka also attempted that, why don't we do it in up to PHC level? And we were involved in training, everything. What I realized from our own experience of implementing that project when we went to community level is, one is, yes, you have infrastructure issue which were resolved for cervical cancer and other things. But acceptance in our place, that was a major issue. For example, women were not comfortable to undergo speculum examinations. Then we thought, why don't we make the ANMs and ASHA workers undergo speculum examination? They themselves are not ready. Unless there is a peer-to-peer interaction, that is what we have learned from HIV program. Peer-to-peer, peer-led interventions are key for community acceptance. Okay, so that is one of the biggest challenge. How do we convince our own health staff? You're looking at COVID now. There is so much vaccine hesitancy among healthcare staff. I think there has to be the ASHA workers, the ANMs, unless they undergo these screenings, the community will not be in a position to accept, or our vision of, detecting these cases early will not work. Because for a community, for a woman, the ASHA worker is the doctor there. For any problem, she will ask the ASHA. If ASHA says, I have not undergone, then the belief sets in. The second challenge, what we have seen in our own, the breast cancer, which we started from the medical college side when we started, I think there is a gap in the communication strategies. Okay, so when we do some kind of a sensitization program, we started with the traditional approach like PowerPoint, using charts, those kind of things. I think that does not sink into community. Community thinks this looks like some high-end disease. That's why they're coming and doing PowerPoint and charts. So there is a gap also in the way we are communicating to convince community to come and accept these services. So we recently got changed these strategies, bringing in more of community sitting in women's support group. We told the student, put some beads inside a cotton ball, ask them to feel different size of beads, so that once they start feeling it, then it may help the woman to come and undergo breast examination. There are many challenges. Not only that, now let's look at, I diagnose somebody as having, there is some cervical changes. Where should the woman go? Woman comes to the district hospital. Now, in the district hospital, where are the facilities to do cryo? There are many infrastructure challenges. Screening is just one part of it. Unless we complete the loop, you will not be able to build confidence at community level. A woman should get confidence that I get diagnosed, I'm assured of some kind of a treatment there or linkage to services. That is where I feel is lacking. One is the way we are communicating. Two, if we convince and bring people, there are structural issues which needs to be addressed. Yeah.
Sure. No, sir, absolutely well said, sir. We have to ensure that there is, closing of loop. Just finding somebody and saying you have cancer and do what you want is absolutely not at all. I mean, it's not even ethical. So very good point. And the other point you made about training the trainer, or even changing the mindset of people who are going to do the screening, A&M training. That's an amazing experiment that you've done. And so moving on to Dr. Vineet. So do you also face similar problems when you go on the ground, when you do cancer camps or screening camps, Dr. Vineet? And what are the big things that we need to fix on the ground?
Yeah, absolutely. When we, 4 years before, when we started working on cancer care in India, so we did a landscape exercise first to better understand what exists, because our program was primarily focusing on strengthening public health system to deliver those services. As Professor Balu said, the current, I would say, still the existing infrastructure in public health system can be referred in two terms: fractured. So that is the word which should be used. Along the continuum, a lot of there are resource incapabilities within the system. Providers availability is also a challenge for this. Infrastructure, competencies, and there isn't any systematic approach to address this. Though Government of India has launched the program on prevention and control of cancers and other 3 NCDs since 2010, but a lot of focused effort, I would say, structured effort has not been done to translate those guidelines into implementation design or implementation model to say. So once we did the landscape exercise, and while we did the landscape exercise, some things came up really upfront. Like there wasn't any diagnostic services for cancers available till the district hospitals. No any curative services available, including cryo, colpos, far thought of. No Hpv Dna testing services available. So there were a lot of systems, infrastructure, and those resources issues were there. So what we did was we came up with a simplified resource stratified pathway, as WHO says, that how in a resource constrained situation, they have defined 3 pathways for the developed countries, for the intermediate and the lower resource countries. So we came up with a solution that in the current situation, what should be the pathway for care? And we tried to implement that. Simultaneously, we did also work on working with the system for the resource allocation, so that at least the district level hospital can be built in for the diagnostic capabilities. And we had the opportunity for public-private partnership, which is a recent thing which has come up, and which did.
Can you share one of the? Sorry, can you share one of the type of policies you implemented, sir, because of this guideline you mentioned?
Sure. So while we, for the screening, we initiated that, we built the capacities of the sub-centers and the providers for mobilization and other things. On the referral continuum, we also developed the capacity of the district hospital for diagnostics. If I give an example for breast cancer, what we were able to do was that it required between USG and histopathology to go with, and biopsy. These were the 3 things which we intended to do as a first level for confirmatory diagnosis. Biopsy, we initiated the biopsy. We helped the government to procure those biopsy guns. Surgeons were already there, and they could do that. The second one was for histopathology. There was an existing public-private partnership at the district hospitals, but histopathology for cancers was not included. We worked with the government to get it included for the second one. Third, the largest challenge was USG machines were available at the facilities, but for breast USG, it required a linear probe, which was not available, high frequency linear probe. So we worked with the government so that they can procure, and they did procure on the pilot basis. So we got 3 things placed. And the second challenge was to build the competency of the provider to do the breast USGs, because the people who were doing who were performing USG, which were largely abdominal for MNH care, it wasn't they weren't confident on that. So we tied up with Tata Memorial Hospital and SGPGI Lucknow to provide hands-on training for these radiologists for 3 days, so that they can get exposed to it and learn from that. And while we did this, we also came to know what are the various components: resources requirement, competency requirement, and from where the competencies can be imparted. And I'm happy to share that the district hospital Lucknow, and similarly Ranchi and 2 in Maharashtra, we had been able to operationalize for this diagnostics. And going forward, government is planning to scale this strategy for additional 10 districts in each state.
Excellent. I think, it's really good to see that there's a lot of learning already. And the good aspect of JPIGO is that it's already like, John Hopkins sort of sponsored thing. So you can look at these infrastructure or closing the loop with not too much, I guess, too much pressure on funding. Maybe, of course, you will have your own challenges there, but I think it's very interesting. Also, you mentioned that for breast cancer, when we look at, let's say we do Niramai screening on the ground, for people who are positive, we suggest an ultrasound. And the point you mentioned about just buy a probe, because most district hospitals and taluka hospitals will have an USG because they have so many pregnant women being treated for scan, right? Hopefully that's a working ultrasound there, and just buying a probe is sufficient. I think that's a direct, benefit and use that we can actually take away as Niramai, right? To try and see how to increase the capacity in the upstream processes, and several other points you mentioned. Thank you so much for that. And Suresh sir, so what are your thoughts? And I know that unlike Japago, for example, we do not have the sort of the godfather, if I can use that, in terms of sponsoring funding. How do you actually raise funds for your camps, and how do you actually get people come together? What kind of local support are the villages that you require? How do you get this all done? Because there are several people in this audience also who want to do good to community, and they want to just get started and say, can I conduct camp on my own? And I would, that's a similar way that KCS also started with the, volunteers coming in from as doctors, which is also a very, very unique thing that I saw. I work with many, many senior doctors here. So how do you actually raise funds, and how do you actually get started on the campsites?
So actually, Cancer Society is running only through donors and philanthropists. We have got several MO with different hospitals where they are sending their doctors for our camps. Of course, if they detected cancer is detected, they are going to give some free service of. Can you hear me, madam? Can you hear me?
Yes, sir. Yes, sir. Very
okay.
nice.
So, so many of the hospitals we are having an MOU, and also diagnostic also we are having MOU where the MRI scan they are giving 50% discount for the patient sent through Cancer Society. To do a camp, the money is most important, madam, because of course Pap Smear and all we have to pay the money to the lab, and then only we can do it. Many of the organizations like Lions Club, Rotary, Innal Wheel, and other some of the organizations, they are coming forward to have the camps, madam. Especially in rural camps, we find little bit difficult because without the local support of the without the local support, we cannot do the camps. First, we will go there, we will give the wide publicity, and we will. Suppose if at all we are doing in panchayat or local this one, we will catch hold of the corporator or the panchayat member to organize the camp. Like that, we are facing little bit difficulty. And ours is an NGO being, we have got ATG exemptions also. Anybody can donate. Especially when we do cancer detection on second Saturday, some organization, they will come voluntarily and pay money. On this day, you can do the camp on our banner. So like that, we are doing, madam.
Sure. Thank you. Thank you, sir. Of course, so the challenges gets added on, right? Because of the money pressure also. I completely appreciate the fact that yes, sir. Please go ahead.
And one more thing I want to tell you, like Dr. Balu said, no, madam, we have already given a representation to government to do training for ASHA workers, madam. Okay. Because any organization cannot cover all the persons for camp, for the detection. So that is why we have requested training the trainer is very, very important for that. Mm-hmm. That's why we have requested that also. And of course, we have started school awareness programs also. In colleges also, we are giving lot of awareness. We have given more than 5,000, 6,000 students. We have given awareness talk about cancer, hygiene of the how they should be. We have taken our senior doctors and we have given talk for them, madam.
Okay. Thank you very much, sir. So one last round of questions, given that we have 10 more minutes to close. So Dr. Balu, you mentioned about it is an opportunity, use of medical centers and, connecting them to PHCs and then conducting these community screenings is an opportunity. Do you have any sort of suggestions to the government or policies or some kind of infrastructure or reformation of framework that can enable close some of the challenges, address some of the challenges that you mentioned?
Yeah, I think I was looking at data, see, although my main area of work is TB, my personal interest is also in cancers because of our own reasons. Just before this talk, I was looking at data for, let's say TB, 2019, roughly in India, 1 lakh people, 79 or 70. COVID, 1. But let's look at the impact these have made. Because of COVID, the government sent entire resources into it. Not only that, there was advocacy done with medical colleges. The reason I'm quoting this is, I think we are blessed in India that most of the districts have medical colleges. Okay, at least in Karnataka, every district except for 2 or 3 have medical colleges. Now, what COVID did, government made Medical Council of India, now NMC, to make sure all the medical colleges will have a virology lab. Okay, that is the first point. Why? Because 1.5 lakh people were dying and cases were crossing. Let's look at TB, TB and HIV. Because the government is committed to end TB by 2025, again, they wanted to increase the infrastructure in testing for drug resistance TB. Drug resistance TB is going up. Again, there was a advocacy done by whoever, the government made sure that now all the medical colleges should have facility to admit and treat MDR, TB and HIV patients. Now, my worry is, I think more than 5-6 lakhs people die from cancer every year, right? Now, where are we failing? I think that is first we need to understand. There is something wrong in the way either we are advocating with the government, or whatever we are advocating maybe not the right thing for the government to consider. Okay, so my thinking is we need to tap these medical colleges, partner with societies like JAPIO and Karnataka Cancer Society, and we have a very good proactive university. At least I can comment on the Karnataka part. Try to see how we can use these medical college resources to train, mentor, and support outreach camps. See, we can't, because I really appreciate their efforts, but Karnataka Cancer Society can't go and do screening in every village and every PHC every year. It's practically not possible. So the only option left is now we need to see how do we integrate these into existing outreach camps being done by the government. We have a RBSK scheme which goes in the vehicle to do a school health checkup. If they be utilized. We have so many other NCD activities happening. Somehow I feel the first step is to take the advocacy level and see where are we failing when so many women or men are dying of cancer. It's not that money is not there. If I was just looking at the money, if you go to a primary health center, each PHC has a budget of nearly 1 to 2 lakh, which they can use it for on their own for whatever they want. So they can use it for procuring Pap Smear or whatever, minimum things are required. Even the district hospital, I think they have enough money to procure cryotherapy machine. It's not expensive. It costs roughly 1 to 2 lakh. I think somewhere we need to see where are we failing in doing advocacy. And I add the structural changes. Biggest problem what I see in the way the cancer program run is, I don't think we have a good structure for doing advocacy. Let's just to give you an example of HIV. HIV program is in fact an HIV, PLHIV driven program. That means the patient are part of the program and how it gets implemented, what it gets benefited. So somewhere, I think something like they did in the HIV program where they built HIV positive networks. I think there is a need to look at how do we build the network of people surviving with cancers. They should be part of the government policies along with NGOs and some technical experts. It may be there, but as far as my knowledge goes, I think these are the two gaps. One, fail in advocacy, and two, somewhere we are not looked at creating the structures.
Okay. No, I think very well said, sir. So patient advocacy. Of course, some of the cases patients are not coming forward to talk about it, but there are quite a few patients who have approached us also and said, what can I do? How can I help? And this is a wonderful way. And also putting this up to the government is, I think we will all come together and see how we can address this together. So thank you very much for those insights, sir. And Dr. Vineet, do you agree with what Dr. Balu sir mentioned? Or do you see we could do something more to get the government and the policymakers interested, in this as well?
Yeah, I absolutely agree with Professor Balu that a lot of effort, strategic efforts, were bringing in all the key decision makers together and having that advocacy that what does the program actually require, what is in place, and what the gaps are. That will be really helpful. But I would like to also bring in another perspective. Since NCDs, especially cancer programs in India, they're less than a decade when they were initiated. There is a lot of gap in the program management capacities at the various levels. So it's also because when we talk about service delivery, it's actually an ecosystem. So somebody a service provider, somebody a awareness creator, somebody is actually providing diagnostic services, somebody looking at data and helping the decisions make or take a realistic and feasible decision. So all the ecosystems has to be brought together, and which primarily means that there need to be some program management expertise on this. If we just compare the cancer prevention efforts which are being made, if with tuberculosis or HIV, we'll find that this ecosystem is quite robust and very efficient in other programs. I won't say that this is just because that more efforts had been made there. It also that people have been working on this area for more than 2 decades. So that has also helped evolve the programming and help everyone understand their responsibilities. So possibly we should also focus on building the capacities of program management experts in this area, at least one in every district, because every district for cancer would be unique. We have limited resources. When I talk about I talked about the minimal diagnostic, that definitely can happen at the district level. But if you look at tertiary level institutions where the cancer care can be provided, it would be 1 in 10 districts. So the referral pathway will be entirely different, and we will have to come up that how we can break down all the needed services along the continuum of care and try to bring it a level below, so that these tertiary level institutions do not get overburdened. If I give an example, when we started, we did around 2018, we did around 40,000 clinical breast examination, and with the rate of 5% of positivity which came. And we also know that most of them, more than 90% of them would be benign. But since there wasn't any intermediary facility available where they can be, there could be a second level of diagnostics where it could happen. All of them were going to a tertiary level hospital, cancer institutions, overburdening the facility, which is not really needed. And this can be done, this level, second level of screening can be done by a medical officer. But that wasn't available. So we put in those efforts to bring in there. So we will also have to look at, while we define the pathway, build the systems capacity, build people's management capacities to look at. So I'll stop here. So there are a lot of insights. Thanks.
Yeah, no, absolutely, sir. I think system capacity, management capacity, and trying to sort of experiment with different care pathways, like you mentioned, what kind of skills are needed for at every step of the care pathway, and then sharing this as best practices across different such efforts, would be wonderful. And then finally, we can take that to the government. I think well said, sir. Finally, Suresh sir, you get to say the last word of this program, where it's World Cancer Day, and we are all interested in the well-being of people. And so, sir, what is your message to end users? What do they need to do, to prevent and make a better, healthier planet, if you will, right, which is cancer-free? And how can they themselves take care of themselves, and how can they help others take care of cancer or prevent cancer?
It's for me?
Yes, sir. Suresh, sir.
For me. Sir, madam, I request our doctors, faculty members at least in an year, 5 days, let them do some social services. 360 days, let them work for their own. Because when society has given everything to us, in turn we have to give something for the society. That is my request, and I request other members also to do some volunteer work for the NGO like us, and many of the societies NGOs are there. And also I request the people to get checkup once in a year, whether it is a breast or a cervical. If they do, that is more than enough, madam.
Okay, very good, sir. Actually, I think, Dr. Balu, sir, it's an action item for you to train all the clinicians who are coming out and all the people who are in the community medical colleges, particularly, to say, okay, 5 days in a year, please spend.
That's all.
Yes, that's all. So,
no,
anyway,
I think, yeah,
sir,
they have an opportunity now because
yes,
as per the new NMC curriculum, we have an opportunity there where student can actually do an elective where 1 month he
okay,
can spend on whichever subject he wishes. So I
okay,
think we have an opportunity. Maybe Karnataka Cancer Society and others can look at doing advocacy with university and see how do you partner with them, to make use of this medical colleges and their outreach camps and electives, so that we can bring in some structured curriculum into the medical schools.
Of course.
Absolutely, sir. Yeah.
Of course, medical college, they are supporting us, madam, especially community medicine doctors, they are definitely helping us, madam.
Sure, sure. Very nice, very nice. So with that, calling from clinicians, calling to the citizens of India to take care of their own health, once a year screening for breast cancer, cervical cancer, and the common cancer of lung and oral, and probably prostate, all of these. And also, hopefully, taking this message, all of us together, taking this message to the government to try and set up infrastructure to take care of the care pathway once the screening is done. And each one of us, I would always say, each one of us, let's take 5 people around us and spread this news. Maybe every month, talk to 5 more people and talk about the symptoms and why the cancer care is necessary. With this, I think we can enable early detection, at least early diagnosis of symptoms at the minimum, and save many, many, many deaths that are happening due to cancer alone. And thank you very much for the wonderful panel and the different insights that were shared, Dr. Balu sir, Dr. Vineet Srivastava-ji, and Mr. Suresh-ji, for spending your time on a Saturday and coming in and sharing the stories and nuggets. Thank you so much. And over to you, Dr. Lakshmi. And I guess we have Vicky as well available for final comments. Thank you so much.
Thank you very much, madam. Once again, I thank you for giving us an opportunity. Thank you, madam. Thank you.
Thank you, Dr. Geeta. I know you're taking calls from multiple places. Thank you. And thank you to the all-male panels. We didn't decide to do this, but I think it happened. And I think it's a good representation of both genders in the community. Thank you, Dr. Balu. Thank you, Mr. Suresh. Thank you, Dr. Vineet, for this. I would now request Dr. Tanvi to play the second video on the common cancers of men. This is about symptoms of common cancers of men. Tanvi?
Yes.
you, Tanveen. Also, I think I will now come in to propose a vote of thanks. On behalf of the entire Niramai family, I would like to thank Dr. Gopinath for delivering the very concise and insightful keynote lecture, which pretty much set the context for the entire webinar. I also want to thank our panelists from the first panel from such diverse backgrounds coming together to address one major disease burden of cancer. Thank you, Dr. Malliga, Dr. Monika, and Ms. Priya for your time and thoughts. The discussion was very engaging, and I can assure that even I made notes, and I'm sure many others had a lot to take from the discussion. I'm sorry I'm proposing the vote of thanks, but did anybody have questions? I'm sorry, I forgot to ask if there are any questions. Is there any questions? We don't see any in the chat for sure. So I will continue proposing the vote of thanks if there are no more questions. No? Okay. Okay. Yes, I'll continue with my vote of thanks. I will also take this opportunity to thank Dr. Balu, Dr. Vineet, and Mr. Suresh for taking the time out and talking about the larger picture of cancer prevention and screening at a system level and from a bird's point of view. While the challenges that we as a system face are multifaceted, we hope we will be able to assimilate the key takeaways from this discussion and make cancer screening available and accessible to both urban and rural communities. Well, while I have been the face that you are frequently seeing in this webinar, it is a work of my teammates that I'm showcasing. Thank you, Tanveen, for making this look so easy and effortless. I know it was not that. Thank you, Ankita, for creating those videos with as minimal inputs as possible from me. I also thank Dr. Geeta, Dr. Shiva, Surajit, Vicky, and all my colleagues at Niramai for pitching in to do all the background work. And well, the cliche, last but not the least, thank you to the audience who encouraged to bring out such important topics and discuss. You are the reason why we are inspired to have such webinars and talk about it and develop awareness for cancer. Thank you for your patience and interest. And we would be even more thankful if you went out today and got yourself screened from the common cancers. And like Dr. Geeta said, convince 5 people at least around you to get those cancer screenings. So yes, go convince your family and friends to do it as well. Remember, I am and I will. I am in this fight against cancer. Are you? So hope you all join with this fight for cancer. Thank you.
Thank you very much.